if I want to put someone on a continuous EEG monitoring, I can only do 2 before I have no machines left. So you have to kind of use discretion in terms of where am I going to be able to do the most benefit for the folks who are in my care at this point in time.
Fellow Homo sapiens, today meet adult epileptologist, neurologist, and fellow podcast host Michael Kentris from Ohio, US. In fact, today, this is part 1 of 2 with Michael. Today's episode is about the challenges faced by neurologists in rural and often undersourced, comparatively speaking, and generally speaking, areas, and the benefit of telemedicine, the use of which positively exploded during the COVID pandemic. Hello there, Michael. Thank you so much for joining us today. Could you please tell everybody a little bit about yourself in 30 seconds?
Thank you for having me. I'm Michael Kentris. I'm a neurologist in the U.S., in Ohio specifically, and I currently am working in a community hospital setting. I also run the Neurotransmitters podcast, which is mostly focused on neurology education for the curious as well as those in healthcare.
And so tell us a bit more about your position in the community in which you're in, and possibly compared to other environments in which you've worked, because I understand you're in a slightly more sparsely populated rural area. Is that right?
I should specify a little bit. So there's a small urban area, and then around that is a large rural area, because we're kind of centered, for those who know the geography, between Cleveland and Pittsburgh. So about 60 to 70 miles or 120 kilometers, give or take, between those large urban areas. So we've got a large population coming into kind of a central hospital location. So in my previous position, I worked in the epilepsy department. And so we were an epilepsy center there. It was about a 900-bed hospital or so. So I've moved to be closer to family. And in this new hospital, new practice environment, it's a smaller hospital, not an epilepsy center. So we're still looking to try and, at least from my end, I want to provide still that same level of care for epilepsy patients specifically, because that's what I'm trained to do. And so trying to find ways to kind of cope with limited resources has been a bit of a unique challenge over this last year.
And what are the challenges specifically?
I think there are several. One is, and probably the most obvious, there are a lot fewer neurologists just in general. So you have a lot of folks who are being seen primarily by their family physician or an internist. And so they're getting treatment, perhaps not ideal, whether medication choice or dosing, etc. And then, so there's a delay in getting into a neurology clinic. And then for folks who maybe aren't responding, who maybe might be falling into the medically refractory camp in epilepsy, getting that next step in testing, that usually means going all the way to these other centers like Cleveland Clinic or other university hospitals that are quite a ways away, which, as everybody who's listening probably knows, travel, especially over those distances, can be very challenging for someone with epilepsy.
Especially as often, if we have a refractory epilepsy, generally legally not allowed to drive.
Right.
And how does one reach, the area where they're going to be able to get this? I presume you're potentially talking about like EEG, MRI, video telemetry, etc.
Absolutely.
Okay. And how do you deal with the situation?
So it's been, a little difficult in terms of getting the right diagnosis and getting the right treatment. So a lot of times, I'm primarily working in the hospital at present. So a lot of times folks, they have a breakthrough seizure, a breakthrough event of some kind. And so they come in, and unfortunately, I'm just kind of seeing a little snapshot of their life. But I see a medication regimen where they're on 2 or 3 different medications. And I'm like, well, these don't work well together at all.
Wow.
And so I'll give them a plan to follow over the next 2 or 3 months in terms of start weaning this one, increase this level, check your level of this medication in a month. And then I'll have them follow up with one of my colleagues who, they're not epileptologists, but they're still in neurology practice. And so we can kind of set things on autopilot for a period of time at least, and, trying to be available to my colleagues in the community who might have questions on that front. I think one of the other challenges is a lot when we're not sure if we have the right diagnosis or not, because we don't have a proper epilepsy monitoring unit. In fact, for our whole hospital, we only have 3 EEG machines. So it's a little challenging, right? Because I will sometimes, and we have, in addition to folks who are coming in with spells, we also have folks in the intensive care unit who might not be responding. So if I want to put someone on a continuous EEG monitoring, I can only do 2 before I have no machines left. And so you have to kind of use discretion in terms of where am I going to be able to do the most benefit for the folks who are in my care at this point in time.
Yeah.
And so you do have to do a bit more triaging than you might otherwise. And I am fortunate in that at least I have the training to do that.
Right.
A lot of neurologists don't have that training in neurophysiology or epilepsy to be as comfortable reading those 24-hour studies. And obviously that is a skill set that needs some training. But I've been trying to introduce that to the community, and I've had a couple folks come in over, I guess more than a couple, over the last year or so, where like, all right, well, you keep having these spells, you've been having these for years, and you've never been to an epilepsy unit or, had it, the proper thing. So you kind of try and get it sorted. And sometimes you catch the spells, sometimes you don't. But again, it's not a proper unit because a lot of times these folks are on meds, and I can't take them off those medications safely because they don't have the 24/7, eyes on them. So that's some of the limitations that we're kind of dealing with in this setting. Obviously we try and get them to a proper epilepsy center, but a lot of folks, and I don't know if this is the same in the UK, but it's more than 20 miles away. They was like, I don't know if I want to go all the way to that big area. The traffic's so bad, on and on and on. And so it becomes this challenge. Like, people want care in their community, and trying to make it so that you can deliver that care is challenging, both from like a personnel as well as just a straight up resources perspective.
So what do you see as being the potential, gosh, it's a rather grand word, but solutions to these challenges? Because I guess there's, staff, there's training, there's transport, there's awareness, there's so many things. What needs to be done locally, regionally, and nationally?
I think you're seeing a little bit of this where you're kind of, and to some degree, even with private companies, where you're seeing more services where they have, sometimes a stable of neurophysiologists and epileptologists who are interpreting studies, and they will do home monitoring, things like that, and sometimes even video monitoring, which has been quite impressive. We also are, I think, seeing some more sort of hub and spoke type models with large academic centers where you have maybe a general neurologist or other type of clinician, kind of boots on the ground, so to speak, and then they are able to put the person on EEG, and you have someone at a central location kind of reading for a few different hospitals. I'm actually doing something similar to that myself intermittently for my former employer. I still read EEGs for them periodically.
Your fingers in so many pies.
Got to keep your skills up, right? But yeah, I think silver lining perhaps from the COVID pandemic is that we did see this explosion in the utilization of telemedicine. At least in the United States, it was something that insurance wouldn't pay for most of the time, or that you couldn't do across state lines. And that's still a little dicey state line wise, but there have been some interstate compacts which have made some of that a little smoother in certain situations. So that way you're able to, sure, you can't, go halfway across the country to see that nationally renowned specialist, but maybe you can do a telemedicine visit and still get, good continuity, good follow-up. So I think there is this increasing accessibility of these specialists to people in rather remote areas. And I think we're just starting to see that, take off a bit over the past couple of years.
I mean, it's great for people to be able to access this care, advice, etc. remotely, but also we need more humans to be able to provide that.
Right.
In what sort of stage of the process are we at least to your knowledge, in the US, in increasing the number of clinicians who can actually provide the service remotely?
So that's actually a great question, and one that I've thought about a lot, actually. Like most of the Western world, we're kind of at an inverted population demographic at the moment. So as the baby boomer generation gets older, there's going to be increasing neurologic demand. So the demand is also expected to increase over the next 10 to 20 years. So to your question, what can we do about it? Well, we need to train more neurologists is the short answer. One of my goals has been, because this is a community hospital, but it is a community teaching hospital, so there's still they're training internists and family physicians and general surgeons. And there is interest from the administration in starting a residency program for neurologists, which I would love. Unfortunately, kind of a little bit of a catch-22 in as much as we need to recruit enough neurologists to have a good faculty that we can provide a good teaching environment for said trainees. But I think that, I would say, it's incumbent upon neurologists to take an active teaching role in as much as, if you're not part of a neurology residency, to be very active in teaching our primary care physicians so that they're able to be better equipped to identify and treat folks with epilepsy and other neurologic disorders for that matter. So I think that's a very important part. I know it's kind of tongue-in-cheek to say that you want to be like a lifelong learner, but I do think it is important. And to really make sure that you get that foundational training during your residency and even medical school. If a lot of medical schools don't have mandatory neurology rotations, so you may, in the U.S. at least, there are many schools where you could go all the way through 4 years of medical school, 3+ years of residency training, and you never do a neurology rotation at all.
That's nuts.
Yeah. I think so.
That sounds a bit crazy. So I guess what you're saying is that, well, we have to, we don't want to get into politics, but basically politicians and people providing funding for all these types of things, but especially neurology and epileptology, we have to be thinking long term as well as short term in order to, keep things going.
Oh, absolutely.
But also plan for the future, which is not too far ahead, really.
Closer every day.
Yeah. Well, look, everybody, very much related to what we've just been speaking of is going to be the second part of Michael and my chat. And we're going to be speaking about diagnosis of epilepsy and frequent mistakes that may be made in diagnosis and how we can try and avoid those. So please make sure you subscribe so that you can receive notifications for next week's episode. Thank you so much for joining us, Michael.
Thank you.